Hi, everyone. Thanks for joining this session, which I think is going to be very interesting, on how health is financed in low and middle-income countries and why it matters for doing good. So for this particular session, we have a very interesting personality who's going to be breaking it down for us. So we have Peter Koziol, and Peter is a senior strategy officer at the Bill and Melinda Gates Foundation.
So I work at the Gates Foundation, which is one of the largest non-state funders of global health. And the reason that I want to give this talk is because while I think effective altruists rightly spend a lot of time thinking about the money, how much we give, to what causes, and how effectively, that if we want to really fully maximize our impact, that's only the start. Because the cost-effective interventions that we talk so much about operate within a complex health system, and understanding, at least on a top level, how that system is structured in finance can help us make better decisions. So 2 goals for today. One, I want to help you build your mental model for how health funding flows through this system across low and middle income countries. And second, I want to take a little bit of time to share some of my reflections on what this means for all of us. So to start, before getting into where the money flows, let's talk about how much there is, which is not very much. So this is a map or a chart of total health expenditure per person from all sources per capita. And so you can see lower middle income countries and low income countries, which is where half the world's population lives. In most of those countries, the average spending per person is on the order of $100 per year. And for the poorest countries, it's just $44 a year. And so given this low level of spending, it shouldn't be a surprise that in these countries, they account for 90% of child deaths globally. So to put into perspective, like what $44 a year can buy, some costs of some things we might think about. Malaria bed nets, somewhere between $4 and $10 a person. A small but non-negligible part of that budget. Pregnancy care, and remember, it's something like 10% of women give birth in any given year in many of these countries. And that's $55 as a starting cost between antenatal care, an uncomplicated delivery, postnatal care visits. And then those kids need their vaccines, and that can easily add up to $100 or more. And finally, thinking about some of the more burdensome infectious diseases, HIV or tuberculosis can have very expensive treatments. So a year of dolutegravir, which is the sort of lowest cost treatment to control HIV, is like $45 at a procurement price. That's before thinking about all the service delivery that goes into that. And a number of countries in Southern Africa have between 20 and 30% HIV positivity rate. So looking at a budget of as low as, in the $44 a year range, this is really burdensome. So let's talk about where the money comes from. 3 basic sources. The individual seeking care can pay for this, and I'm lumping prepaid private insurance into this category, though that is a relatively small share in most of the poorer countries. The country government can pay for it, and this is through tax expenditures, and typically might exist across country government, state government, local government, through many different agencies. And then there's donor money, and this is where many of us come in. It's both in the foreign aid world, but also private philanthropy. So I'm gonna go a little bit more into each of these sources of funding. So individual expenditure is the largest source of out-of-pocket funding with out-of-pocket funding is roughly 85% of this, and in the poorest countries and among the poorest communities, it's close to 100% of the funding. In terms of what that gets spent on, it's a mix of consumables like medicines or diagnostics, and I think that's especially the case in an outpatient setting like a primary healthcare clinic. In some cases, there may also be fees for service, and that's particularly the case with private facilities, which a patient may go to if it's the only facility near them, if there are staff attendance issues at the local public facility. So it's adding costs to people who really can't afford it. And finally, particularly for hospital stays, and this might be around a pregnancy and delivery, there can be non-medical costs like food and lodging. And so for for pregnancy care, which many countries have made officially free, can still be burdensome to families as they pay for food while they're there, a family member staying nearby. So lots of costs coming from poor people in these countries. The second biggest slice of this funding is from government, which becomes larger as countries get richer, both absolutely and as a share of the total pie. And it's split across many different ministries, levels of government, each with their own mandates and purviews. And this, I think, two implications of this. One is that it can make it challenging for governments to improve the efficiency of how they're allocating their resources, because a lot of these pots of money aren't fungible between each other. I think relevant for us here today is it also makes it very hard to track down exactly how it's being spent and what it's going to. So this is some work that the World Bank pulled together a number of years ago. It is a very high-level breakdown, but by function, when we're thinking what is the government spending money on, a lot of different things, but maybe the places where it's most over-indexed, hospitals and the administration of the system as a whole, and by disease, probably relatively less on infectious disease causes that have large donor contributions, and relatively more on non-communicable diseases or the overall system cost that can't be allocated to a particular disease area. Okay. And finally, we're going to get to the slide where a lot of us fit in. And if you're squinting and trying to find the green on this, it's because donor funding is a very small slice of the overall pie, even accounting for foreign aid and private philanthropy. Just at a high level, some of the different categories here. There's bilateral aid, which is rich countries directly providing donations. There's a lot of ways that's used. That's also something that's really at risk right now, as many rich country governments are pulling back in terms of how much they give. The middle number of rows here is really a variety of different multilaterals. The Global Fund and Gavi give a large amount of support for particular health commodities, be they drugs, vaccines. Development banks provide concessionary loans to low and middle income country governments that help them strengthen the quality of their healthcare system over time. And then there are a number of UN agencies that provide technical assistance and create normative guidance for how countries can be operating their health systems in an evidence-based way. And then finally, there's this slice that we fit into, private philanthropy at about $12 billion a year going to health. And that's roughly half of that is the Gates Foundation. When you're looking at what EA-related sort of the effective giving community is giving, that's probably only in the order of a couple $100 million a year. And so all of this totals up to roughly $50 billion a year, though much of that money is at risk right now. I think the takeaway here is we're a small slice of a small slice in terms of where the money is in the global health system. So I want to bring this together in a perhaps too cheeky map of the whole system. So across different settings of care, we have tertiary hospitals delivering the most complex care. There may be district hospitals where a complicated birth could happen, or perhaps severe childhood infections. And then primary care, which may be delivered either in the community or at a clinic. So obviously, households are paying something across basically all of these settings. And that may be directly, it may be through private insurance. And then we start getting into the government bucket. So probably the first place people think of is the Ministry of Health. And so this map, based on much of what they do is overall sector administration. This map is based roughly on Nigeria, where they also have clinical responsibilities for a network of tertiary hospitals. But there's another federal agency that does primary health care. And then on top of that, there are vertical disease programs. And in some countries, these are structured to be part of the Ministry of Health. In others, they may be standalone. At the state level, there may be yet more funding flowing in similar or different structures. And then finally, local government often has a role to play, particularly in primary health care. So now we get to the donors, and adding some more arrows. Multilateral development banks, typically going through federal agencies. You might have Gavi and the Global Fund providing commodities to various agencies at different levels of government. Bilateral aid, which can really do anything from capital investment to build a new hospital, up through sector-wide support channeled on budget through the Ministry of Health. Foundations, in a similar way, the Gates Foundation has grants across all of these levels of government across many countries. And then there are the NGOs, and they show up in a number of different places in the system. They might be providing technical assistance to a government agency. They might be a contractor of a government agency providing direct services in various settings. And they may be working directly with facilities or with households, be that as part of a study or just to provide care in a community. So obviously, there are a lot of green arrows on this. And remember, this is only, in Nigeria, it's less than 10% of the total funding, and that's pretty common across many settings. So when you think about this from the perspective of the healthcare worker at a facility, the procurement manager, the local administrator, there are a lot of different competing uses of their time and their decision making. And I think that's something that we ought to be mindful of as we think about how you layer on additional effective interventions. So, my conclusion. The takeaways here: the poorest, sickest countries spend very little money on healthcare. Even an intervention that's, you hear, for only $3 we can do X. Well, in a place where the government health expenditure is less than $10 a person, $3 is a lot of money. Effective interventions then operate in this system rife with complexity. While it may be a simple and straightforward intervention, there's a broad system of finding the patients, paying the healthcare workers, getting the supply chain together. So that's something to really think about there. And finally, the donor money is a small slice of the overall health funding pie. So in terms of what that means for us in this room, I think, one, being wary of introducing perverse incentives. In many cases, bilateral donor aid has been funding at scale childhood vaccines, malaria bed nets, some of the most cost-effective interventions. But as we've seen recently, as donor aid gets disrupted, that can be very problematic as some of those programs get the rug pulled out from under them. I think we should be cautious when adding complexity. That doesn't mean that it's never a good idea to add a new intervention to a facility. I think if we're doing it with a path to how we might scale it, to learn more, it can be worth it, but it's a cost that should be considered. I think for the people in this audience who are running a small NGO, for instance, thinking about your path to scale is probably, it shouldn't be, in the long run, GiveWell is going to give me money. Because, again, small slice of a small pie. I would imagine, thought experiment, what if we doubled the number of GiveWell top charities? That would be really, really good, and also a drop in the bucket compared to even marginal improvements to the quality of government healthcare expenditure. And so finally, I think maybe the role for private philanthropy, which has a lot of flexibility in how it spends its money. In my mind, the thing we should be focusing on most with that money is how you change the cost of healthcare in the future. Make it cheaper or better for people to be able to spend those dollars at scale. And that could happen as data and research on healthcare priorities. Can happen with new delivery models. I think many of the small charities trying to pilot something, just figure out how to make it work, are providing a really valuable service as long as it can then be connected to scale. And finally, research and development on new products. This is something that the Gates Foundation puts a lot of its energy into. And a lot of that energy is on making things cheaper, finding ways to lower the costs of various products. I guess I'll pause there and talk to Zach.
So maybe just to kick us off. Number one, I think the issue of global health or just health financing, especially for low and middle income countries, has been on the minds of people for a long time. I think the Gates Foundation has supported various interventions around health in LMICs. I'm from Zambia, so I know this for a fact. So maybe the first question, from your experience or from your perspective, do you think that right now global health funding or financing for LMICs is at its peak? Do you think it's at its peak?
So I'm worried that with foreign aid cuts, like, yes, in some ways, that $50 billion a year coming from outside of low and middle income countries largely and flowing to low and middle income countries, like, it's at risk of dropping, in some cases, quite precipitously. But, and here's my case for positivity around this, is while that'll definitely have bad impacts in the near term, in part because it's happening precipitously, the political economy of this is that both private philanthropists, but especially governments of low and middle income countries have an opportunity to respond and may have the political willpower to be able to increase their financing and take more control of their health systems. So donor philanthropy for health may in fact be at a peak, but I think that the amount of money being spent on health in these countries, I hope over the medium term is going to be increasing still. And so, yeah.
Okay, that's a good point. So I think there is also a world where, as you said from your presentation, the slice that is actually coming from, charities and philanthropies is actually very, very small compared to what is actually existing in terms of health financing for LMICs. So there's maybe a question there from maybe your projection or just your thoughts around this topic. Do you think there's ever a time that will come where, let's say, philanthropic funding surpasses government funding in health?
No, I mean, I think that the resources of government are just with the power to tax, create all of this, and particularly as while it's been a bumpy road, in the long run, countries have been getting richer. I certainly hope that a broader set of philanthropists become more and more generous, and I would love to see foreign aid turn back around and bring more money into the system. Mm-hmm. But I think government is that's where the future of health spending is.
That's a good point. So, and there are lots of questions that are coming in, so thank you, everyone. I hope I can get through all these questions with some time to spare. Maybe I'll start off with something also that continues to, create sort of overlap in, the EA community as a body. When it comes to finance and AI, someone is asking in the group, how do you see AI's upcoming role in global health, including in financing? And I know this is maybe a very interesting question for you.
So AI is pretty broad. A couple of things that I'm excited about is potential avenues that could be promising. I think on the drug discovery, finding better or cheaper drugs, or just lowering the cost of doing drug development and clinical trials, I think that could be pretty powerful. Again, change the production function of health, make it cheaper for people to get healthcare in the future.
That's right.
I think that, frankly, just this getting information about what's happening in the system today is going to be something. So, we talk about all of those arrows, the difficulty of mapping, the difficulty of just figuring out what government is spending its money on. Let's just have Claude read all of the documents and stitch it together. And yes, it can't do that right now, but in 3 or 4 years, maybe. I think clinical decision support could potentially be a promising area. Again, so the knowledge of doctors, the ability, their bandwidth to work through things, if you can find tools that help create more access to care, I think AI could be powerful there. And I'm sure, those are just ideas that I've heard tossed around now. There's a lot of uncertainty. I hope a lot of innovation will help with more.
Perfect, thank you. So another interesting one. Given that donor money is such a small percentage, I know we've touched on this just now, but building on that, should efforts be more focused on improving government programs? And I'm deliberately leaving out the government funding part. Should efforts be, focused on improving government programs? And then the question goes on to talk about, or maybe this should be focused more on growth. Are there donors that are actually being effective? And I think to maybe make it even more complex for you.
Oh boy.
So do you think that there are actually ways that we can create a system that resonates around effective giving towards health? Because I think maybe there are people who think about effective giving and trying to reduce how much money is being wasted in the process, so that we can increase the amount that is actually arriving to the target communities.
Yeah, so I think I would love to see more effectiveness across all the slices there. Donor aid being targeted at the most effective things. I think in many cases, the most effective things are not just the highest, return on investment particular interventions, but maybe, funding technical assistance to particular governments. I think you want domestic country demand for that service, and there's promising work in many countries to provide fairly flexible support to the Ministry of Health to structure in a way that lets them get around some of all of the silos, create a hook to bring in funding or to bring in to change policy across various agencies and state level health officials. There were a lot of parts to that, but yeah, I think that we should get more effective, yeah.
I agree. I think many people also agree here. Yeah, we just solved the first problem. So maybe going even beyond that, and I think anyone who is in the global health space is very, concerned, and rightly so, with the recent developments in terms of the shrinking commitments towards, global health funding from the traditional partners. So maybe to cut the question short, how, if in any way, these decisions or the aid cuts impacting decision-making in global health funding from your perspective as an organization?
Yeah, I think it's certainly a thing that a lot of people in my organization are spending a lot of time thinking about. I think the cost is more important than ever, thinking about how you bring down costs of products, of delivery. I think there are short-term gaps, and philanthropy should while I think philanthropy, you saw the scale of the green slice, it's not going to fill these gaps in their entirety, but figuring out how to make the short-term disruptions as, kill as few people as possible is a really good use of some of that money.
Yeah, I think that's a very useful point. So for context, I think some of the disruptions that happened so suddenly, right? Organizations and governments did not have time to adjust for some of the shock adjustments that came. So there were programs and projects that were running in active process that suddenly did not have money, suddenly did not have funding, including from overheads to actually implementation funding. And I think the point you raise on creating a sort of gap financing just to mitigate the impact, I think, has significant value to that end. Well, thank you so much. And unfortunately, that's all the time we had. I wish we could continue going on this, but just want to, first of all, thank you so much for being part of this very exciting conversation, and to you, Peter, especially, for breaking it down for us. And we do hope that we can continue to provide some kind of support for global health in LMICs, because there are certainly areas of need. So thank you so much for joining us.
Yeah, and thank you to Zach.